Welcome to Rural Health Today. I'm JJ Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. I'm thrilled to be in the studio today with special guest, now Lauren LaPine Ray.
Mm-hmm. That's correct.
Congratulations, by the way, on
Thank
your
you.
recent marriage. It's great to have you now among us married people, right? It's great. It's awesome. It's amazing. But today we're in the studio to talk about something even more serious than that, which is rural health and rural health access, rural health advocacy, rural health as it relates to what we face now with the federal government's recent legislation that was passed and its impact to us and all those things to unpack. I think we'd rather talk about marriage. But instead, it is my pleasure to have in the studio you've been here before, but you haven't been in person.
No, I have never been in person.
But you were on the program before. You were at Rural Health Rising. You've been on our show before. Really an amazing insight that you give from your perspective working with hospitals across the state of Michigan. You also travel to Lansing, Washington, other places. Certainly a wealth of information, incredible insights on rural hospitals. And you have to admit that we're facing some significant headwinds, regardless if we're rural or urban, but rural specifically because of our funding makeup. So it's great to have you in the studio officially. Lauren LaPine Ray, it's great to have you here, Vice President of
Policy and Rural Health.
There it is, Policy and Rural Health for Michigan Health and Hospital Association, often referred to as MHA for us. So it's great to have you in the studio. We're just going to hit several topics today. Among those topics we're going to talk about are some of the impacts of the federal legislation on rural hospitals. But before we do that, for those listeners who don't know you, could you give us a brief introduction, your background, how long have you been at MHA, what do you do there, those type of things?
Yep, happy to. And thank you again for having me here today, JJ. It's a true honor to be a part of the work that you're doing here with your team. So I have been with the Michigan Health and Hospital Association for just over 4 years now. I've held various roles in that time, but throughout that time, I've been our internal lead for rural health. And so I'm really tasked with meeting with our small and rural hospital CEOs, hearing about your unique challenges and needs, and then figuring out how to build a bridge between our policy and our advocacy work to make sure that what we're doing at the association is very much tailored to support the variety of rural hospitals that we have in our state. Before I was at the association, I spent 6 years at the Michigan Public Health Institute leading state and federal public health initiatives. And before that, I did a short stint at the Michigan Department of Health and Human Services. So my background is in public health. I have a master's in public health from Michigan State. And I am in the midst of a doctoral program at the University of Illinois, Chicago, pursuing a doctorate in public health that I can't wait for it to be done.
So when do we get to call you Dr. LaPine Ray? When do we get to do that?
Yeah, if everything goes well, it could happen by the end of this year would be when I defend my dissertation.
This is great.
So, we'll see.
That's awesome. Well, it's an exciting time, certainly well-earned because it's a lot of work and you're balancing so much in your life. I want to start by talking about one of the most important things that you're doing right now, and that is advocacy for rural hospitals. Now, let's take out of the equation, MHA does a great job at representing all of our members. But if you were to paint a picture today of what rural health looks like, all right, in our current state of what we're facing, cause for concern, are we giving a five fire alarm? Where are we at with rural health as it stands today?
Yeah, it's a great question. I think if I go back to the conversations that I've had recently with our rural health leaders, many of them have a large degree of uncertainty. There's a lot of unknowns. And in the past, historically, healthcare always has some unknowns. But right now, given the cuts that we are going to face after the passage of the One Big Beautiful Bill Act and the proposed cuts at the state level, there is a ton of uncertainty in our rural hospitals. I think there's even some fear in our rural communities across the state about how these cuts are going to impact the provision of healthcare in rural areas.
In general.
So I think that there are common themes across the state that we're hearing from rural hospitals. There's a lot of uncertainty about how to handle Medicaid redeterminations, since we know that the rural areas of our state tend to have the highest rates of Medicaid beneficiaries. So trying to figure out how rural hospitals are going to deal with supporting patients through that process is top of mind, I think, for our rural hospital leaders. We also know that there have been many pharmacies that have been shuttered across the U.S. and across Michigan. And so there continues to be concern about how to access affordable drugs in rural areas, making the threats to the 340B drug pricing program even more of a concern in our rural areas. And the last thing I would lift up is I think there's a lot of consternation about access to obstetrics and maternity care in rural areas as we continue to see those types of services taken offline due to the incredibly low reimbursement rates and the challenges to recruit incredibly qualified staff to provide those services.
So today we're in the studio talking about the rural health challenges that we face right now, the future of cuts to Medicaid, Medicare, and other vital funding sources right around the corner that we're going to be experiencing, not just federally, but also on a state basis. Many states are passing budgets in their fiscal year right now, which are basically annihilating rural health funding, and it's a concern. Michigan is doing that currently right now. We're in the fight of our lives for that as well. There's been a lot of talk about the Rural Health Transformation Fund, which has been set up federally, passed through. State gets to make application, file that with CMS. And for hospitals that need it the most, what does that mean? Is it reimbursement? Is it payments? What does that look like? Is it projects? And we're going to talk about that today with Lauren LaPine, who is here to share her perspective and insight as a state expert in the healthcare legislation and policy. I'm excited to talk and to dive into the first topic, which is in the state budget just last week, the state representatives said rural hospitals are going to be fine. Yes, we're just kind of mirroring what the federal government's doing at the state level, but you've got that rural transformation money coming. That's $250 billion divided by states. All right, let's get down to some reality here. First of all, that money is designated for specific purposes. What I'd like for you to do, Lauren, our listeners are across the country, so this isn't just about Michigan. This fund it's been directed by the federal government, and our listeners need to understand, what does this encompass? Can you take us through the program, what it is, what it's intended to do, what are the parameters? Could you give us a high-level overview of that, please, for our listeners? And remember, they're listening from throughout the country, so as it pertains to the federal piece of legislation.
Yep, absolutely. Happy to do so. So the Rural Health Transformation Program is a $50 billion fund that was allocated as part of the One Big Beautiful Bill Act that the Trump administration passed right after the 4th of July. And this fund was created really at the last minute when negotiations were occurring to try to get enough votes to pass that One Big Beautiful Bill Act. The main driver of this in the beginning was actually Alaska Congresswoman Lisa Murkowski. And rural hospitals, I think, are something that's very important to her, since Alaska is, I think, basically like entirely
99%.
Rural. Don't quote me on that, but that's my guess.
Yeah, I would guess.
And so that was really the concession of, we will put in this $50 billion for all states. No territories are eligible, and states will have to apply to access the funding. The funds are set up in kind of an interesting way. So it's $50 billion total across all 50 states. But it will be divided up in half. So 25% or $25 billion will be distributed equally among all states that have an approved plan. And I think that language about an approved plan is really important. And you have to get into the nitty-gritty of the bill language to understand that the CMS administrator has a lot of leeway in determining which states will have approved applications and those that will not.
And so, Lauren, just correct me if I'm wrong, because I could be. Isn't it sole authority to determine what that is? I mean, so it doesn't go back to Congress.
Nope.
It doesn't go to each district's representative. It doesn't go to the governor of the state. It's strictly with the CMS director, correct? I just want to make that clarification, because sometimes, the bureaucracy gets caught up in this, but truly this is at one person's discretion. Now, I would assume that there's going to be people advising the CMS director, which is Dr. Oz, on these. But at the end of the day, all 50 applications are going to be reviewed by him or a designee, assuming it's him. Decisions will be made solely by one person.
Yeah, I think that's
pretty overwhelming.
I think that's a very fair interpretation. One would hope that the applications will be scored against the guidance that we're waiting to see from CMS, and that Congress would have some insight and guidance into what goes into that. But yes, there are a number of pieces in that One Big Beautiful Bill Act that gives the CMS administrator the sole authority.
And you've been attending a lot of CMS webinars, a few of those. Obviously, you're our lead for Michigan Hospital Association. What is CMS saying about guidance and timeline and some of those things as it relates to the rollout of this and then the submission?
Yeah, so as of today, September 5th, we have not seen any of the guidance out of CMS, and states are required to submit their applications by early December because the bill says that funds have to be awarded by December 31st of 2025. So we're on a really short time frame. So what we've heard from CMS leaders so far is that the guidance should come in mid-September. States will have the opportunity to pose questions to CMS in the month of October. And then states will need to submit what we've heard in the month of November, their full plan that says how they plan to spend the dollars, who will receive those dollars, and how they will track on the spending of those dollars. So as of today, we have a pretty significant amount of unknowns before us.
Significant amount of unknowns. So let's say, all right, so here we are. CMS director collects these applications. The applications will hopefully will be scored. I mean, I'm assuming that I feel that would be to our benefit, but beyond that, you're listening to what CMS is saying. We have some guidance over here, a little bit of it. We have a timeline that we now know. My understanding is one application and done.
Yep.
If you're denied as a state, you don't come back for application number 2, correct?
Yes, that's our understanding. So the interesting thing about this is that states have to submit one application for a 5-year funding period. So the funds will go from FY26 to the end of fiscal year 2030. And so you submit one time, and you do not have a chance to revise an application if CMS deems that it does not meet the mark. So one-time application.
Divided by 5 years, right?
Divided by 5 years, yep.
To your knowledge, does it have to be equal payments for each of the respective years, or can it be a graduated type of approach?
That's a good question, and one that I don't think we have an answer to yet. What we've been told is that there will be $10 billion allocated each year, but we don't have a good understanding of what the requirements would be around that.
Okay.
Yeah.
Okay, so that's the mechanics of it. All right, we know it's in place. I do want to comment on the politics of it, because it's often been used both at the federal and now in Michigan at the state level to say that rural hospitals are going to be fine. I want you to restate, please, for our listeners across the country, this cannot and will not be accepted to replace cuts to the provider tax or any incremental type programs. Is that correct?
That's correct. We anticipate more than $6 billion, billion with a B, of cuts over the same time period. And we could potentially, at the very max, get $250 million a year, which is, I think, less than 2% of that total $6 billion across the same time frame. So while this is being used as a talking point to justify the broader Medicaid cuts, we are, certainly appreciative of any focus on rural, but at the same time, it is nothing compared to the broader cuts that are coming to rural hospitals across our state.
And it cannot supplant the cuts. That's the issue.
No.
So let's talk about what it can do, if you feel comfortable with that today. Obviously there are some parameters. Could you identify what the federal government has identified as tranches or program areas that they want to focus on? We know it can't be direct funds, to replace the provider tax. So what is it that it can provide for in each of those communities?
Yeah, so again, based on what we know from the bill and not from the guidance from CMS that we don't have yet, we know that states have to elect to work on at least 3 initiatives out of a range of 6 or 7. And those kind of categories are relatively broad. One is focusing funds on technology, innovation, AI, remote patient monitoring, things of that nature. Another is focusing on addressing chronic disease and preventing preventable diseases. So focusing on healthy foods, the built environment, things of that nature. There is a category to support transportation and things that have to deal with the social drivers of health. There is a category that exists around focusing on value-based care models. And states really have to kind of back into those strategies. So it's not necessarily like this program is set up and each local community or state is given the chance to pick what works for them. We need to be able to make a pitch for how we can use the funds in the way that CMS and the Trump administration has put forth the programming.
So, Lauren, in each of the respective states, let's just take Michigan for an example. Who's the lead? Who is going to be presenting this, and what autonomy do they have to establish some of these parameters?
Yep. So the lead in every state, as it's written in the bill, is the governor and the governor's team, and the governor can delegate their authority to another entity. So I've heard from colleagues from other state hospital associations that are approaching this. Their states are approaching this in different ways. Some, their Department of Health is the lead. Some, their governor is really keeping it in-house. In Michigan, our understanding as of today is that our governor's office is very closely involved in the work, but also intends to partner very closely with the Michigan Department of Health and Human Services. And the Michigan Department of Health and Human Services will likely be the one that will submit the application and will ultimately be the one that will receive the funds and then distribute it to the eligible entities.
I think the other important aspect of this is there's so many competing interests. And I think we just have to address that because across the country, it's happening. We're hearing stories right now of organizations that are kind of trying to get the ear of governors in respective states or whoever the legislative body or administrative body is administering this. And so, we're no different. Obviously, you at the MHA have established a task force, but it's a limited task force. It's not like whatever we say is going to happen. But what is the goal of the task force, and what is our hope to come out of that task force?
Yeah, that's a great question. So when the One Big Beautiful Bill Act was passed and this Rural Health Transformation Program was created, our MHA board chair this year, Bill Manns, was really insightful in his approach to saying this is going to be important to Michigan and to our rural hospitals. We need to convene a small panel of experts to advise on this. And we obviously came to you as our chair, JJ, to lead this effort, along with 5 other rural hospital CEOs representing every region of our state. And so we have this task force that is working really closely to provide recommendations for our governor's office and for MDHHS to consider on how the funds could best be used to support rural hospitals. But like you alluded to, we are not the only entities that are eligible, unfortunately. While this program really was intended to support rural hospitals, the way the bill was written includes other eligible entities. So every federally qualified health center across the country, regardless of if they are rural or not, is eligible to receive the funding. Community mental health agencies are also eligible. Certified community behavioral health clinics are eligible. Opioid treatment providers are also eligible to receive funds, as are all of the rural health clinics, of which we know that many rural hospitals, of course, also have a rural health clinic within your 4 walls. So we have our task force that's working really closely on behalf of rural hospitals, but we at the association are also working really closely with the Michigan Primary Care Association that represents the FQHCs, the Community Mental Health Association of Michigan, as well as the Michigan Center for Rural Health that works really closely with rural health clinics. And our intent with this, as you alluded to in your question, was really to try to row the boat in the same direction. Because what we're seeing from other states is that there's a little bit of a food fight that's occurring, for lack of a better phrase, where entities are trying to lobby to say that, more of the funds should go to one specific category than the other. And in Michigan, we have a really good track record of collaborating with other similar groups and stakeholders. And it was actually the Michigan Primary Care Association that came to our CEO, Brian Peters, early on and said, we would really like to think about this together with you instead of charting different paths. And I think that has helped us be successful so far. We are working with those groups very closely with the governor's team and with the leads at Michigan Department of Health and Human Services. And again, the hope is that we create an attractive application with a very small amount of information and try to get as much of the eligible funding to Michigan, to rural providers and rural hospitals as we can.
So you have had personally a tremendous amount of conversations with organizations that are outside of the traditional hospitals, and you have been trying to balance some of those conversations with what are their needs.
Mhm.
What are you hearing as a common theme among Michigan of what the needs could be with this funding?
Mhm.
You care to share? You don't have to give the strategy, but maybe talk. Are there any common themes
Yeah.
among these organizations?
Yeah, I would say one of the common themes that I honestly, personally was surprised by is the interest in using funding to support technology broadly.
Hmm.
I wasn't necessarily anticipating to hear from as many rural hospitals as we have so far about the need to invest in their electronic medical records or wanting to use platforms for ambient listening for
Hmm.
providers.
Hmm.
I think that our hospitals are thinking really strategically, knowing that these Medicaid cuts are coming. How can they lighten the load for providers and the individuals that are really doing the work to make it easier to provide care and mitigate challenges as they come? And I think in today's environment, there are some solutions with technology to do that. So I've heard that from hospitals. I've also heard that from the partners in the community mental health space, as well as the federally qualified health centers. So there might be some potential to pursue something in that arena.
Yeah.
We've also heard, I think another theme is the need to focus on recruitment and retention for rural
Huge
providers,
piece.
which is massive. And I think I forgot earlier on to list that in one of the eligible strategies
Hmm.
that you can apply for funding for. And so, again, we've heard from rural hospitals really loudly that they're doing things right now that are working
Hmm.
to recruit and retain staff. And if they were to have additional funding, they could expand and bolster those. And again, that applies across FQHCs and community mental health agencies as well, as we know that we continue to have really significant provider shortages in our state and across the country.
Yeah, and then the other challenges, which are some programs have already been cut or proposed to be cut out of budgets, and Michigan included, and federally for reimbursement of loans and education, and that's devastating to attract physicians to a rural community like ours. We often give them education forgiveness, loan forgiveness, but some of those programs are being rolled back and scaled back, and that's going to impact the level of care that we will see coming to rural communities just like Hillsdale. That's a challenge.
Yeah.
And so hopefully that fight will continue. So great job with all the work you've done around this. I mean, it's a huge marathon you're running, but it's a short race. You are in the race of your life because we have a very short window to get the application in, hopefully to bring all the players together. I want to commend you in the work that you've done already on this. I just wish you Godspeed in carrying through to get what Michigan needs. And then the real issue is, will Michigan get anything? Because that is still on the table. The legislation does not require the funding to be distributed equally for all of it among all the states. So there is a political element, Lauren, that you've been involved in politics for many years. There's a political element here which could impact negatively Michigan's ability to even obtain any of that funding. So we have to make sure everyone is on the same page. There's collaboration at every level. Everyone is rowing that boat in the same direction. And then thank you for the leadership of MHA. As we transition that conversation, let's go to the broader picture of rural health in this country. You know, we know what the challenges have been fighting this specific piece of legislation, One Big Beautiful Bill. But there were a lot of headwinds happening before then. Hospitals were closing at an exponential rate. Since 2010, over 150 hospitals have closed in this country. The One Big Beautiful Bill is going to accelerate this. We know. We're told that by nonpartisan organizations and pundits across the country who did the research and identified hundreds of hospitals are at risk of closing. What can we do? What advice would you give? You know, we are facing some of the most tumultuous times in our industry right now. The One Big Beautiful Bill is going to impact it even more dangerously. But what advice would you give to hospitals across the country listening of what they can do to fight some of these dangerous, I'm going to say, legislative pieces that have been passed, but the dangerous precedent that's been established at the federal level is now trickling down to states. Like Michigan is witnessing almost on exact same level of what the federal government just did. same language, same nomenclature, same talking points, fraud, waste, abuse, everything's the same. What advice would you give CEOs who are listening across this country about what they can do to fight some of these challenges?
Yeah, I have two pieces of advice that I think are applicable in this situation. The first is to get really good at collaborating and partnering. I think if I use Michigan as an example, that I think is applicable across the country, we are unique in the perspective in Michigan that we have all of our hospitals in the state are under the MHA umbrella.
Mm-hmm.
And that might seem like a pretty insignificant talking point, but that makes us better advocating for hospitals, whether those be rural or urban hospitals, because we have all the members under the tent.
That's right.
And we have a really rich history of bringing our rural hospitals together and rowing the boat in the same direction. So if I'm a rural hospital CEO right now, I'm thinking about how can I get to know other leaders that are going through the same challenges that I am, and how can we figure out potentially how to create some joint solutions that will support both of our hospitals. So I would be thinking a lot about collaboration and partnership. I also, and you do an excellent job at this at Hillsdale, I would be building up my advocacy efforts. And advocacy can mean talking to your state lawmakers and your federal lawmakers. It also can mean talking to your local school boards and your city council. All politics is local.
It is.
And so I would be spending some time getting to know the people who are making the decisions for my state and for my country and for my family. And I think it's important that we continue to use our voice in productive ways to talk about how some of the things that are being proposed will have really negative impacts on the health and well-being of Michiganders or people living in the United States in general. So really, I think it would come down for me to build those collaborations and partnerships and really lean into the advocacy piece. And advocacy isn't something that a lot of people are comfortable with. It's something that in many ways you have to learn. And so I'd also encourage folks that are listening to reach out to your state associations or your other member and stakeholder groups and figure out how to get in contact with the people that have real influence on how you live your life and how you do the work that you do every day.
Sage advice from a career advocator for rural health. I want to ask you this question. What keeps you up at night as you think about rural health, as you think about working with hospitals like me, Oaklawn, Owasso? As you think about that, what keeps you up at night thinking, how are they going to do it? What is it? What is the biggest burden in your mind for these rural hospitals right now?
Yeah, I don't want to be too specific, but if I'm probably thinking of a conversation that I had this morning with a rural hospital CEO that is really struggling to maintain birthing services in a really rural area. And we have areas of our state where we have pretty significant birthing deserts. And so if I'm a rural hospital CEO, I'd be thinking about how to maintain that true community service in my region for women and families. And I raise this one in particular because I haven't heard of any innovative or new ideas anywhere else in the country about how to maintain.
Everyone's struggling with it.
Everyone is struggling with this specific issue. And in many ways, it's one of those issues that sometimes you can solve an issue by throwing money at it. And in this situation, that doesn't seem to be working. That doesn't seem to be working either.
It isn't.
And so that is a concern, I think, that we have generally. How do we maintain access to maternity care for women and families? And that might mean thinking about different alternative care models that we haven't thought of in the past. But our traditional models might not be working in the current demographics and the current economic structure. So that is something that I think broadly across the country, I don't know that you can find any state that isn't grappling in some way with a maternity desert and how that also impacts longer term access to care.
Yeah, and I know these are off script questions, so I apologize for that. But as you talk with your CEOs around the state, and for you even the country, the common theme is what?
The common theme is the reimbursement rate is really low. It's really hard to find an OBGYN that particularly is willing to live in a rural area.
Yeah.
And I think something that we don't talk about very often is the volumes are really decreasing. So people are having less children.
Yeah.
And
true.
providers tend to be concerned if they cannot practice their skills
Correct.
as often as they need to stay sharp, which you certainly want them to stay sharp when
Yeah.
you're delivering a baby. And so maintaining these services in areas where the volume is dropping also makes it really challenging. So it's really a catch-22 because you have multiple challenges that are impacting the same problem.
Your insight is just so valuable for us in hospitals like Hillsdale because you're meeting with other CEOs, you're meeting across Michigan, you're meeting out of Michigan, going to Washington, lobbying and having conversations about how to keep rural hospitals propped up. And I just want to thank you for the work that you've done. It's been great insight today. A lot of work ahead of you. Obviously, as we try to wade through, we don't even know what is going to come out of the one big, beautiful bill when it's all done. But there's a lot. There's a lot happening already. We know that work requirements. We know that redetermination, twice a year, a lot of things that are going to impact the number of patients that are covered under Medicaid drastically will change. And those hospitals that were counting on that reimbursement to get that payment, now we're going to shift that population over to either bad debt or charity care. And hospitals are not going to make it as a result of that. So continue the advocacy that you're doing for us. I appreciate it. Hopefully, my hope and my greatest, request would be among the people listening today, lobby your representatives. And if they don't change to support rural health, get them out of office. It's that simple. You cannot sustain rural health in this country with continued cuts that we are receiving, not only at the federal, but at the state level. And if no one wants to support rural health today, we need to ask a question of ourselves. Are they worthy of being in those positions at the federal or state level if they don't take care of the least among us? And the least among us are those in the obstetrics unit. It's moms that are delivering without prenatal care that just show up in our ERs. This is the population. It's the population that I once lived for 18 years of my life on Medicaid when my parents, with 7 children, used Medicaid as a way to gather health insurance for us in our household. And you know what? We're not waste. We're not fraud. We're not abuse. We are products now in our community who are contributing back. And this is what we say to Washington and to Lansing, is that these are about lives we're talking about. It's not politics. It's innocent people who need care and access to care. And when that's gone, unfortunately, the communities will crumble. Their economic infrastructure will crumble. All of their health outcomes will be very, very bad. And so goes their community. Once they lose a program like OB, usually what we find is other programs are quickly cut and the hospital closes. It's a true story. It always happens. So, Lauren, it's been great to have you on the podcast today. And we like to wrap up with a closing segment. It's called Rural Health Recommendations. And for every guest that we have in the studio, we ask them to contribute a recommendation that a young, new, aspiring leader can learn from. Maybe a recommendation on how to deal with difficult people, how to deal with congressional leaders, how to deal with your state politics, or maybe just some sage advice on thriving in a rural environment today, which is very, very difficult. We have a lot of CEOs who are retiring right now. I don't know if you've read Becker's latest report, but CEOs are migrating out of this business very quickly, retiring or otherwise finding other careers. It's a very tough industry. And young leaders are finding, challenges in entering rural health leadership. So what would you say to that young leader who's rising up, or maybe it's a CEO has been in the office for 4 or 5 years? What advice would you give them or recommendation on how to keep on keeping on?
I think my advice for a young leader would be you are never going to know everything right off the bat. Healthcare is inherently incredibly complex.
Extremely.
And so my advice would be every day I read a bill, I read a policy, I find something that I have no idea what it's talking about. But then you have to sit down and you have to research it and you have to educate yourself and you have to learn about it. And that part is really important.
It is.
If I think about the leaders that I look up to and that I think do an excellent job in their field, those are the ones that will say quite comfortably, I don't know, but I will find out.
Mm-hmm.
And so that would be my advice to a young leader. It's okay not to know everything.
It is. It's healthy.
It's quite healthy,
Yes.
and no one knows everything.
Yeah.
But be really diligent about learning and figuring out the things that you don't know, because it'll make you a better leader in the long run.
Lauren LaPine, I hope to have you back in the studio to be able to call you Doctor.
One day.
Okay.
One
Hopefully next year, right? I'm not going to have you back until I can do it.
Okay, that's
so
great.
so I will, next time I introduce you, you will be Dr. Lauren LaPine. It has been great to have you in the studio today, and thank you for joining us on Rural Health. Catch us on our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday, wherever you get your podcasts. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you subscribe to your show so you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.